Welcome, ladies and gentlemen, to the ESRS webinar on contemporary management of central sleep apnea, a broadcast sponsored by Zoll Respicardia. Central sleep apnea is part of the larger group of sleep-related breathing disorders that also comprise snoring, obstructive sleep apnea, and sleep-related hyperventilation. It is common knowledge that central respiratory events may figure to some extent in obstructive sleep apnea syndromes, and as a fact, central and obstructive sleep apnea may share common pathophysiological mechanisms. On the other hand, pure forms of central sleep apnea may dominate the clinical picture. As we will learn from the forthcoming lectures, central sleep apnea is a condition with many different causes. When it presents, the condition may be difficult to treat. The efficacy of conventional treatments may be unsatisfactory in some cases. In recent years, Phrenic stimulation has been introduced as a safe and viable treatment alternative for selected patients with central sleep apnea. In the current webinar, expert opinion will be presented on the rationale of central sleep apnea treatment and on the indications for the different treatment options. As I mentioned, this webinar is sponsored by Zoll Respicardia. The views expressed by the speakers and the parties they represent are by their own account and do not necessarily reflect the opinions or policies of the ESRS. All speakers will disclose any potential conflicts of interest at the beginning of their presentation. Before starting, I'd like to mention some housekeeping points. During and after the presentations, there is a possibility of asking questions, and we encourage the audience to drop comments and questions via the Zoom Q&A box, not the traditional chat box, but the questions and answers box. After each presentation, we will address a couple of questions, and at the end of the webinar, some time will be reserved for a general discussion and for answering some additional inquiries that are relevant to the subject. This session is being recorded for offline watching purposes. Without any further ado, I would like to introduce our first speaker, Professor Dr. Johan Verbraecken. Johan is a pulmonologist and ESRS certified somnologist. He is the coordinator of the Multidisciplinary Sleep Disorder Center of the Antwerp University Hospital in Belgium. He is a prolific researcher and co-author of more than 300 publications by now. He has been entrusted with several mandates in different scientific societies, including the ESRS, the European Respiratory Society, and the Belgian Sleep Society, of which he is the past president. Johan will give the introductory lecture on pathophysiology and clinical relevance of central sleep apnea. Johan, this virtual floor is yours.
Thank you, Professor Pevernagie, Dirk, for the very kind introduction. And first of all, I would like to thank the ESRS board and yourselves for the invitation to give a talk on the pathophysiology and the clinical relevance of central sleep apnea. So first of all, I would like to share my conflict of interest, which is mainly related to income that I receive for educational activities, a sleep course that I organize in my hospital, and I also receive some income for consultancies and lectures that I gave for different parties. So central sleep apnea is part of the sleep-related breathing disorders, which is one of the 7 categories of sleep disorders that has been defined by the International Classification of Sleep Disorders 3 by the American Academy of Sleep Medicine, apart from obstructive sleep apnea and hypoventilation syndrome. Now, central sleep apnea is characterized by a cessation of flow during at least 10 seconds in the absence of respiratory effort. It can be associated with desaturation and a final arousal. Now, in the spectrum of central sleep apnea, you have 8 different subcategories, of which mainly 8 are applicable to adults, and also a few categories are also present in children, usually in newborn or in the early stage of childhood. In adults and in adolescents, you can have central sleep apnea with Hans-Stokes breathing, central sleep apnea due to a medical disorder without Hans-Stokes breathing, Hans-Stokes breathing due to high altitude periodic breathing, and central sleep apnea due to a medication or substance. So these 4 categories have an underlying disease or mechanism and are associated with or without periodic breathing. And then we have 2 additional categories where there is no underlying disease, which is primarily the primary central sleep apnea without any underlying cause. And then you have the treatment emergent central sleep apnea, also called TEXA, which is primarily an obstructive sleep apnea syndrome where CPAP is applied and where central apneas develop. Now, when you look to recordings with the appearance of central sleep apnea, then you can observe different presentations of central sleep apnea. So there are cases where you only have very short ventilatory periods and rather short apneic periods, while on the other hand, there are also patients who present with quite long ventilatory periods and with also rather long apnea periods. So this indicates that central sleep apnea is a heterogeneous disorder, which was already pointed out almost or more than 30 years ago by Douglas Bradley, one of the popes of central sleep apnea from Toronto. In either case, central sleep apnea is characterized by a transient withdrawal of the central ventilatory drive to the respiratory muscles. And this is also associated with an increase in the length of the cycle. So that is the accumulation of the ventilatory period and the apneic period. So altogether the cycle length, which is much longer in those with Hans-Stokes breathing compared to those who only have an idiopathic presentation of central sleep apnea. Now, we usually speak about a syndrome, which means that you also need to have symptoms. And according to the ICSD-3 manual, different symptoms have been proposed that have to be present, at least one symptom, in order to make the diagnosis of central sleep apnea. Among them, you have sleepiness, difficulty to fall asleep or to maintain sleep, also frequent wake-up, so a problem of maintaining sleep again, non-restorative sleep, dyspnea at night, and also witnessed apneas are part of the palette of symptoms that can be present in central sleep apnea. But there are also criteria on an objective base based on polysomnography, which are mainly based on the frequency of the central events. So at least 5 central apneas or hypopneas per hour of sleep. And also at least 50% of all respiratory events has to be of central origin. In high altitude, you don't have to prove that these respiratory events are present, so that is a different approach. Now, on top of these criteria, for Hans-Stokes breathing, there are additional criteria. So you need to have at least 3 consecutive apneas or hypopneas with the crescendo, decrescendo features in the breathing amplitude. The index has to be at least 5, and the cycle length, so the period of ventilation and apnea, has to have a duration of more than 40 seconds. Additional criterion is that the recording has to have a duration of at least 2 hours, which is not really difficult to obtain. In 2017, the ERS published an ERS task force document where a new definition or a new name was proposed for Stokes breathing, namely periodic breathing with apnea in the setting of heart failure. Another category that has also been observed quite often is opioid-induced central sleep apnea. This is central sleep apnea related to the intake of opioids, and these patients have an irregular breathing pattern, also described as ataxic breathing, with also a variable amplitude in the ventilatory periods. So in this category of central sleep apnea, you can also define different severity categories from mild, moderate to severe, according to the frequency, of course, and whether there are more clusters of breathing and more irregularity. Now, opioid-induced central sleep apnea is related to the dose, so it's a dose-dependent relationship with the occurrence of central sleep apnea. So those who have an intake of more than 200 milligram morphine have a likelihood to develop central sleep apnea, which is 15% higher than those who do not take opioids. And in those who take more than 200 milligram, the majority has central sleep apnea. This form of central sleep apnea is also very common in those who use methadone as a substitute for morphine. So in either case, the lower the dose of narcotics, the better, and the less central sleep apnea will occur. So this is important for the pain clinics to take that into account. Then a last category I would like to show you is treatment emergent central sleep apnea. This is a polysomnography during a CPAP titration night where inadequately high CPAP pressures were applied up to 14 and 15 millibar, and you can see that when the pressure is increased, that also the number of central apneas is rising. So then it's important to offer these patients a much lower pressure in order to control ventilation. Now, what is the prevalence of central sleep apnea? That is something that is not well documented. We know very well that the prevalence of obstructive sleep apnea is very high, up to 80% of the population, on a population level, presents with at least 5 events per hour of sleep. For central sleep apnea, this is much less reported. One single paper from also almost 25 or even more years ago has reported a prevalence of 0.4%, but they used a threshold for the AHI of more than 10. And a more recent paper reported a prevalence in men of 1.8% and 0.2% in women, with an AHI of more than 5. This is based on a study from the Sleep Heart Health cohort. So this is just to show you that also in women, obstructive sleep apnea is quite common based on the study of Raphael Heinzer from Lausanne. Now, the prevalence of central sleep apnea is much higher in specific conditions. In 1993, we published a paper describing the prevalence of idiopathic central sleep apnea in a referred population to our sleep lab, and we found that 4.3% of the patients presented with central sleep apnea based on an old-fashioned definition, where an obstructive apnea index of less than 5 had to be present and an AHI overall of more than 10. In chronic heart failure, central sleep apnea is highly prevalent, up to 50%, which is also dependent on the severity of the chronic heart failure and also to the level of dyspnea that patients perceive during the disease course. In stroke, at least in the acute phase, central sleep apnea is very common. The Stokes breathing is then the type of central sleep apnea, but overall 25% has central sleep apnea. But also in acromegaly, between 10 and 30% has central sleep apnea, and in Parkinson's disease, central sleep apnea can also be very common. Finally, chronic kidney disease, also at least 1/4 of the patients has central sleep apnea. As said, opioid users have very high levels of central sleep apnea. It's very common, up to 50% or maybe even higher, dependent on how much opioids are used. And DEXA is something that is quite common as well, but it can disappear when you follow up these patients over time. So if you then restudy the patients, then after 3 months, less than 3% still has central sleep apnea. At high altitude, according to the height, 25 to 100% of the people presents with central sleep apnea. Now, how to explain why some patients develop central sleep apnea? And that can be explained, that can be explained by destabilization of the respiratory control system. Sorry, my phone is going on and I cannot switch it off. So again, excuse me. Okay, it stops now. Sorry. So how can we explain the pathophysiology? That is related to the fact that ventilation during sleep is ruled by the feedback control system that we have. And in this system, output is created by the breathing center in the brainstem. It gives output to the ventilatory pump, and the ventilatory pump then defines changes in blood gases and CO2, which are sensed by the chemoreceptors. And according to the sensitivity of these chemoreceptors, input is given to the breathing center in the brainstem. Now, in such a system, instability can take place. If you have chronic hyperventilation, then there will be a decrease in CO2, an increase in oxygen that can then be sensed by the chemoreceptors. When the chemoreceptors then are hypersensitive for CO2 or for oxygen deficit, you get an inappropriate increase in the input of the brainstem, and then this can also then lead to more instability with more output as well to the lungs. Also, arousals can have an impact on the brainstem, changes in the acid-base balance, in the cerebral blood flow, in the central chemoreceptors as well. This all can change the output to the ventilatory pump. So altogether, this system is then in a kind of overdrive, which leads to destabilization of the ventilatory system, which can finally lead to central sleep apnea. So overall, there is an increased respiratory drive. Now, how to understand and to observe whether there is an increased respiratory drive? That is, or can be documented by looking to the breathing response for a certain disturbance that can occur. So if the breathing response is high compared to the breathing disturbance, then we define it as a high loop gain. So it's the ratio of the response over the breathing disturbance. If the response is not that high, then we define it as a low loop gain, and that also means that there is less instability in the feedback control loop. Now, when there is increased instability and an increased respiratory drive, this will lead to hyperventilation. This will drive CO2 below a certain threshold, CO2 level that we need to ventilate. So if CO2 is lower than this CO2 threshold, or also called apnea threshold, then automatically an apnea will occur. During the apnea, CO2 will accumulate, and at the end, this increased level of CO2 will lead to an arousal, and hyperventilation will take place in the ventilatory period that follows the apnea. And during that episode, CO2 is lowered again. If the drive is too high, then CO2 is driven below this CO2 threshold. So it's a vicious circle, and what you can then find is a pattern of cycling with increases and decreases in CO2, which then leads to periodic briefing with an increase in ventilation again and a decrease and disappearance of flow again. Now, a low level of CO2 is also a characteristic of or a predictor of central sleep apnea in chronic heart failure. Apart from male sex, also age and atrial fibrillation, which are also predictors of central sleep apnea. What is also important are changes in sensitivity for CO2 and oxygen according to the sleep stage. So the lowest sensitivity is present during REM sleep. During wakefulness, you have a much higher sensitivity, which is the case for hypoxia. This is a hypoxic ventilatory response, and at the right side you have the CO2 response curve, the hypercapnic ventilatory response curve. Also here, during REM sleep, you have the lowest sensitivity. Now, if you have an arousal, then you have a very fast switch from sleep to wake and to sleep again. So these switches between the different stages of consciousness can also induce instability in this feedback control system. This is an illustration on how these pathophysiological mechanisms work in patients with chronic heart failure. In these patients, you have lung congestion. This leads to stimulation of receptors in the lung tissues. This leads to hyperventilation. Due to the hyperventilation, you get a reduction in CO2. This leads to a central apnea. During the apnea, you get an accumulation of CO2 and a drop in oxygen. These changes are sensed by the chemoreceptors, which then finally lead to an arousal response at the level of the cortex. And what is important, also at the same time, you get a release of adrenaline, of an activation of the sympathetic nerve activity. And this increase in catecholamines will also contribute to hyperventilation, and that also leads to an increase in left ventricular afterload. So this also is one of the consequences of central apnea, but overall this leads to a vicious circle. Now, is central sleep apnea clinically relevant? What is the prognostic value and why to look for central apneas? Well, there is one big study that has been published last year looking to the real value of central sleep apnea with respect to survival. And when you have idiopathic central sleep apnea or central sleep apnea without chronic heart failure, then mortality is modest, let's say about 15% over a follow-up period of 20 years. But if patients with chronic heart failure have central sleep apnea, there is a substantial reduction in survival with less than 50% after 20 years. Those who have obstructive apnea, they have a better outcome based on this big observation. What is also interesting is that you have in chronic heart failure, in patients with central sleep apnea, also different phenotypes. At the left side, you have patients of middle age who have slightly overweight. That is category 1. Category 2 are patients who have also middle-aged and or have cardiovascular problems, have pacemaker or defibrillator. The third category are older patients, male and women. Fourth category, older patients with hypoxia. And at the right side, two phenotypes, older patients as well with high BMI or with hypoxia and BMI. This was based on a latent class analysis of a trial of about 500 patients with central sleep apnea, with different severities of left ventricular ejection fraction. And there we look to overall mortality, to life-saving cardiovascular interventions, and to unplanned hospitalizations. And they all received adaptive servo-ventilation. And what was interesting to find is that patients with category 4 and 5, they had the worst survival when they did not use ASV. So it was a comparison study. With the ASV, the survival was much better, but only category 4 and 5 had very poor survival. So those with which are aged and have an elevated BMI or with hypoxia. Finally, I would like to share one interesting idea that came from Winfried Randerath from Solingen, who presented two different features of central sleep apnea in chronic heart failure. Those who have this crescendo-decrescendo pattern with an end expiratory lung volume that is going below the FRC. The FRC is the lung volume at the end of a normal expiration, so shown in blue. So if this end expiratory lung volume is lower, this has also negative consequences. The second pattern, which is also called a positive pattern, these patients have an end expiratory lung volume above the level of the forced respiratory capacity. And these patients, they have a better outcome, or at least this is postulated that these patients will have a better outcome. So that is something that has to be studied. It's work in progress, but at least it's also an interesting approach for patients with chronic heart failure. And this is also reported in the determinants of and included in the determinants of central sleep apnea. If you have a pattern with a negative pattern of end expiratory lung volume, it's a negative predictor among other well-known predictors of poor outcome in central sleep apnea, like a reduced ejection fraction, the male phenotype, elderly with predominantly central sleep apnea. Those who have features of unstable breathing in the context of chronic heart failure. And finally, those who have a high hypoxic burden, that could also be a predictor of poor survival. So now I come to my conclusions. Central sleep apnea is less well studied than obstructive sleep apnea. It's a heterogeneous disease. There's a low prevalence in the general population, but a rather high prevalence in well-defined conditions. Central sleep apnea is characterized by a destabilized respiratory control system, and the prognostic value of central sleep apnea is best documented in patients with chronic heart failure. So thank you very much.
Thank you indeed, Johan, for this very comprehensive review, and which is also up to date. You showed data from very recent presentations. There are two questions for you now already in the Q&A box. And one is, you mentioned a prevalence of 1.8% of CSA in men. And the question is this a prevalence in men with sleep apnea or men in the general population?
It's prevalence, that means in the general population. So it's in a population without any selection, let's say.
Yeah, unselected sample. Yeah.
Yeah.
Another question is about treatment emergent central sleep apnea. One of the delegates asks whether you can use an algorithm to identify it. Maybe that's not so bad an idea, because there's other forms as well, such as treatment persistent central sleep apnea, and how to make the discrimination between these two.
Well, let's say the basic point is that patients with TEXA, they have an underlying obstructive sleep apnea syndrome. They can, of course, have some central apneas, but that has to be less than 25% of the overall number of respiratory events. Then, if you apply CPAP, these central sleep apneas can persist, that there is no increase, or it can increase as well. And if you have an increase, of course, then, and if it is a relevant number, then you can really define it as treatment emergent central sleep apnea. And some have no central apneas before and develop central apneas during application of CPAP. So if the central apnea hypopnea index is at least 5, more than 5, then you're able to make the diagnosis of TEXA.
Thank you, Johan. You might have a look at the questions and answers box because some questions are coming in. We cannot address them all at this time because we will continue, but we might pick out some of them for the final discussion. So, but we have to move on for now, and it's my pleasure to introduce our second speaker, Dr. Jerryll Asin, who is a pulmonologist and ESRS certified somnologist. He is currently the director of the Sleep Medicine Center of Apnoea Hospital in the Netherlands. He is a board member of the Dutch Society of Sleep Medicine, and he will address the topic on conventional treatment modalities of central sleep apnea. Jerryll, please go ahead and start your presentation.
Jerryll, you're on mute.
You're muted. Turn on the mic.
Sorry for that. Thank you, Dirk, for the nice introduction. And I also want to thank the organization for the invitation to speak this afternoon. And it's a great honor for me. No. Don't know why my slides are not moving. Oh yeah. I have some disclosures, as you can see. My talk will be about conventional treatment modalities for central sleep apnea. And in this slide, you can see, as Johan mentioned before, how important it is to have a clear diagnosis as well as looking for underlying causes. And we also have to look for symptoms related to central sleep apnea, which can be used for clinical evaluation of a treatment if we start. In this flow chart, you can, which is made by Winfried Renderrath and his colleagues, we can see the importance of a clear diagnosis, evaluation of symptoms, and the possible underlying cause. And in case of central sleep apnea with the AHI above 15, we should try to optimize, if we can find it, the underlying disease to reduce the burden of the underlying disease, and also try to reduce or withdraw medication or substances causing central sleep apnea. If CSA persists, we should start with CPAP. What do we know about the evidence for CPAP? Several single-center studies have shown a significant reduction in the AHI, reduction in the time of the O2 saturation below 90%, reduction in sympathetic activity, changes in biomarkers of heart failure, and improvement in quality of life. The largest study which have been performed, CPAP for central sleep apnea patients with heart failure, the so-called CANPAP trial, showed a reduction in the AHI. It improved the nocturnal oxygenation, increased the injection fraction, lowered norepinephrine levels, and increased the distance walked in 6 minutes, but it did not affect survival. A post hoc analysis of this study looked at the results of patients in whom the AHI was suppressed below 15. And those patients might improve the most and have a longer heart transplant-free survival than those with the AHI above 15 despite CPAP. The role of oxygen for central sleep apnea has been studied with an evidence-based literature review and meta-analysis. And it shows in the figure you can see that oxygen suppletion for central sleep apnea improves the left ventricle ejection fraction. And it is also able to reduce the AHI significantly. The AASM recommends supplemental oxygen for those individuals with central sleep apnea related to heart failure who are unable to comply with CPAP therapy. What about acetazolamide? This has been studied in a systematic review and meta-analysis. And in this figure, you can see the effect of acetazolamide on the central apnea hypopnea index. Also, patients who were treated with acetazolamide have a higher PO2. It also showed an improvement in the arousal index, total sleep time, and sleep efficiency. Only one study compared the results of acetazolamide in combination with CPAP. Acetazolamide in combination with CPAP was more effective in improving the AHI, but not the SpO2. Acetazolamide did not impact the CPAP adherence. There are some side effects, dose dependent, which sometimes is that disturbing that it is a reason to stop treatment. Acetazolamide seems effective in reducing central sleep apnea. It improved phenotyping. It may be better to find those patients who will respond the best. ASV showed like CPAP improvement in the left ventricle ejection fraction, biomarkers of heart failure, reducing AHI and sympathetic activity, as well as time below the SpO2 of 90%. And it improved the quality of life. One study showed that ASV is superior in suppressing the AHI compared to oxygen, CPAP, and BPAP. A large randomized controlled multi-center, multinational trial was designed to test if AHV could also improve the survival in heart failure patients with reduced ejection fraction and central sleep apnea. But as you can see in the figures showed here, instead of improvement, it seems that ASV had a negative effect on survival, which was quite surprisingly for most of us. There was no clear explanation found, but a proportion of the patients had residual obstructive events with hypoxemia, which could be harmful for those patients. So perhaps that might be at least a part of the explanation. Because of this study, what was ended even before the trial was ended because of the interim analysis. Because of the results, the current advice is not to use ASV for those patients with central sleep apnea who have a reduced ejection fraction. Another ASV study has been performed, the so-called ADVENT-HF study. In this study, they looked at the effect of ASV in heart failure patients with reduced ejection fraction and sleep-disordered breathing. The primary endpoint was all-cause mortality and cardiovascular hospitalization. In 2022, at ESRS, preliminary results were presented, and it showed that there were no changes in mortality, no differences in mortality in the control group and the ASV group. February this year, Bradley and his colleagues published the final results of this study. And although the ASV was capable of reducing central sleep apnea, and patients did benefit of it, there was no change in, no difference in mortality. But at least it showed that elimination of the sleep-disordered breathing was safely. Another interesting study is the PHASE trial. This is a study with real-world data in unselected heart failure patients with sleep-disordered breathing, central sleep apnea, and obstructive sleep apnea were treated with ASV. Johan already showed some slides of this study. Patients were placed in 6 pheno groups, and what you can see is that especially the older men with hypoxia and the older man with overweight or the combination of it, that's respectively group 4, 5, and 6, had the most benefit of ASV treatment. Johan also already talked about treatment emergent central sleep apnea, obstructive sleep apnea treated with CPAP with suddenly occurrence of central sleep apnea, with an incidence about 3.5 to 20%, and in 2/3 of those patients, if you observe them, the central sleep apnea will subside in a period of weeks to months. Treatment emergent central sleep apnea is actually not the case in patients with a mixed sleep apnea, where central sleep apnea also was present at the time of the diagnosis. Actually, those patients are not categorized as treatment emergent central sleep apnea patients. Treatment emergent central sleep apnea also is observed in patients who are treated with mandibular advancement devices and after surgery for OSA surgery. There was a question about what strategy should we use for treatment emergent central sleep apnea, and I think this flow chart shows you quite great how to look at this these patients, and some patients is important. Watchful waiting can help you to find those patients where the central sleep apnea will disappear by itself. In this case, there are some nuances. In those patients who have severe symptoms, you might act some earlier and move over to ASV or BPAP with the backup. I want to go back to this great algorithm for treatment modalities for central sleep apnea. And I would like to add some remarks, especially in those patients with OSA, with persistent central sleep apnea, and those patients with heart failure, with reduced ejection fraction, oxygen, or maybe acetazolamide could be a treatment, an alternative treatment, or a step between moving over to ASV. And also, I would like to add BPAP in case of central sleep apnea in patients with opioid-induced central sleep apnea, because sometimes they are better off with BPAP ST instead of ASV. And also, as an introduction to the next speaker, in case of predominant central sleep apnea, in patients with heart failure with reduced ejection fraction, who do not have a reduction of the AHI below 15 with CPAP, or in those patients who are PEP intolerant, a new treatment strategy might be available. And for that, we have to wait for the next speaker, Rob, in Germany. I want to end with some remarks. A clear diagnosis of central sleep apnea is important. Look for a possible cause. Look for coexisting OSA, treatment emerging central sleep apnea. And in those patients with heart failure, is the ejection fraction preserved or reduced? There's also increasing evidence that central sleep apnea is a heterogeneous condition, and for that, a personalized approach is necessary. Future investigations are needed to reveal the impact of treatment on quality of life, cardiovascular events, and survival in the different types of central sleep apnea. I thank you for your attention, and if there are questions, I will be prepared to answer them.
Thank you very much, Jerryll, for this very nice review. I have some questions coming in the meantime on whom to treat. Very often central sleep apnea is asymptomatic. There have been studies in patients with Cheyne-Stokes respiration and heart failure that about 70% of them may not have any important symptoms. So here's a question. What about asymptomatic patients? Would you treat them or monitor them? And another question is about which symptoms should you treat? Is it only insomnia and excessive daytime sleepiness, or are there any other clinical manifestations you would take into consideration?
It is a very important question, but also a very difficult to answer question. The complaints of patients with heart failure overlap with the complaints of patients with disturbed sleep. But I think if you listen well to what the patient has to tell you, I think you can distinguish those who do have disturbed sleep and those who are having just symptoms of their heart failure.
Mm-hmm.
And personally, I think with so far the lack of advantage in let's say surviving, you have to be cautious to treat asymptomatic patients. We need some tools to see if the patient is having advantage of the treatment.
Yeah.
And maybe if there are new studies, new findings where which could prove that treating also asymptomatic central sleep apnea would be better for the patient, for his clinical outcome, that we also should treat asymptomatic patients. But as I told you before, first treat the underlying condition. In case of heart failure, treat them optimal, and then if they still remain symptomatic and have an AHI above, let's say, 15, I would treat them.
Yeah. So would you also give it a try in case of doubt? If you doubt whether symptoms are related or not to the condition, would you give them a CPAP or ESV trial to see if symptoms improve? Would that be part of your strategy?
I sometimes do. When I'm doubting, that's also the same for patients with an obstructive sleep apnea. Sometimes the patient will tell you afterwards, when you start treatment, oh, I feel better. So in case of doubt, I will do a trial.
Yeah,
But
yeah.
if they don't have any benefit of it, I will ask the patient if he is willing to proceed with the treatment.
Yeah. Thank you, Jerryll. For the sake of time, we will continue and we will address some of the questions that have come in the meantime at the end. So the last speaker for today is Professor Dr. Robin Germany. Dr. Germany is a board-certified cardiologist and Chief Medical Officer of ZOL Respicardia. She is a clinical assistant professor of medicine at the University of Oklahoma in the United States of America, and she followed her training in cardiovascular diseases at University of Oklahoma with additional training in heart failure and electrophysiology. She previously served as the Director of Heart Failure Treatment and Medical Director of the Heart, Lung, and Vascular Clinic at the University of Oklahoma. And her research interest focuses on the development of medical devices to improve the lives of patients with sleep and cardiovascular disorders. The title of her lecture is Phrenic Nerve Stimulation, a Game Changer. Robin, may I invite you for this lecture? Thank you.
Thank you so much. And I very much appreciate ESRS inviting me here today. I am very honored to speak with these two distinguished speakers as well. So thank you very much for inviting me to participate today. Full disclosure, I do work for ZOL Respicardia, and they are the manufacturer of the system that we're going to discuss today. And it's indicated to treat moderate to severe central sleep apnea. And transvenous phrenic nerve stimulation started development almost 17, 18 years ago now. And this is the system that is available in the US currently, and a slightly different system available in Europe. But both of them have the same exact algorithm in them. So it is indicated to treat moderate to severe central sleep apnea. It's a fully implantable system. It's implanted typically by a cardiologist in the same place that they put in pacemakers and defibrillators under conscious sedation. The device itself has one stimulation lead that's either placed in the pericardiophrenac vein, which runs right next to the phrenic nerve on the left side. It's in the same bundle, or in the right brachiocephalic vein. I don't know if you can see my cursor, but right up here. So next to one of the phrenic nerves. And on the highest level, it's designed to stimulate one of the phrenic nerves to move the diaphragm. And the concept is that it's going to stabilize breathing. And we'll look at that just a little bit further. So it's a different concept. Think of negative pressure system versus positive pressure system. And in the development of this, there were a couple of sort of basic concepts. And I'll talk about some of the things that we're learning as we've developed this system. But one was, we thought going in that this would be primarily heart failure patients. So looking for, with an implantable, something that would not need general anesthesia. So this is done through conscious sedation, outpatient procedure. And the other is that these patients have a lot of comorbidities. So everything with the device is automatic. So there's nothing the patient has to do to turn it on, but it comes on automatically at night when the patient goes to bed, and it'll shut off automatically in the morning. So there's nothing the patient needs to remember. And the way that it does that is because it has a position sensor and algorithms in it to help it do that. This is what it looks like on the X-ray. You can see there it has, on the left side, it has 4 different electrodes, so you can program different ways to make certain that it's the lowest amount of energy the patient needs to stimulate that diaphragm. But this is what it's going to look like. About 40% of the patients have a pacemaker defibrillator. So it's almost always put in on the right side, because the thought process is if they don't have one, they might need one later. And there are some benefits to putting the cardiac devices over on that left side. So this is how it decides when it's going to come on. After the device is implanted, there's some diagnostics that are going to actually capture information about when the patient goes to bed each night, when they wake up. And when they come back in at about between 4 and 6 weeks, the device will actually get activated. And they'll look at that diagnostics to talk to the patient to determine when they go to bed. And so the device will only come on during the pre-programmed sleeping time and when the patient is in their sleeping position and when they're relatively quiet. So when they're lying still. If the patient rolls from one quadrant to another, or if they sit up, the therapy will stop. So if the patient stays up late at night or they get up to go to the restroom, the therapy will suspend, and it gives them time when they lay down to get back to sleep. So that does give them some control as well. So if it comes on and they feel it, and they do feel this therapy. So it is not painful. It's not a hiccup. It's not a pulse. Patients will actually describe it as feeling like a breath they take when they don't mean to. So it is, it's interesting. Some patients actually will have the therapy come on before they go to sleep and use it actually to get to sleep. We've had patients describe it as a yoga type breathing, where they're slightly larger, slightly deeper breaths. But other patients prefer to go to sleep before the therapy comes on. So it can be very dependent on the patient, and it is programmed individually for each patient. Most of the time, the breaths are sort of programmed now. We've learned a lot. Most patients can be programmed within a window, but the device actually has the ability to program the shape of the breath as well. So you can program how quickly the diaphragm contracts, how long the breath is held, and how quickly the diaphragm relaxes. So all of that can be programmed for the individual patient. Luckily today, as I said, most of that is set, and we know how to program that before the patient walks in the room, but it can be if you have a patient with lung disease or a patient that needs some special titrations, those can be changed for the individual patient. And this is what it looks like in the sleep lab. So you can see a patient having central apneas and hypoxia. As the therapy comes on, you can see those all stabilize. You can see based on the belts that as we've seen with some titration studies, that this delivers essentially a normal respiratory signal. It's going to stabilize. It's not going to hyperventilate the patient. And we'll talk about in the next slide kind of how it comes on, but just to look at it, everything is basically stabilizing. Oxygen stabilizes. So if you happen to have a high altitude patient, and they're hypoxic at baseline, they will still need oxygen. Sometimes people don't think about that because it's not delivering oxygen on its own, right? If they're hypoxic at baseline, they may still need a little bit of oxygen. Now, the device works a little bit different than you might think of. And some of that is lessons that we've learned over the years. The device actually has 2 algorithms in it. One is that it can augment a breath. So basically wait for the patient to take a breath and augment. But we've found that especially in the Shane-Stokes patients, that these patients actually need to have respiration stabilized. So most of the patients are actually programmed in a set respiratory rate. And that set respiratory rate is slightly slower than their intrinsic respiratory rate. So a little counterintuitive. So for example, if you have this Shane-Stokes patient breathing at a respiratory rate of 16 breaths per minute, we would program that patient at 14 breaths per minute. And it will typically start to move the diaphragm during a hyperpnic phase as the patient is breathing. And it's going to hold that breath slightly, allowing the CO2 to stabilize and preventing the next episode. It will begin the stimulation at a set minimum level, which you can see here is 3.7 milliamps. And then the device is going to look to see if the patient is breathing at that set respiratory rate. If the patient is not, and if you look at the airflow signal, I think on this example, that's the easiest place to see this. You can see that breathing is not completely regular. Then the device is going to increase the stimulation. So here to 3.9. And it's going to look again. And to my eye at 3.9, things look fairly stable. But the device actually says, no, you're not quite stable. And it walks it on up to 4. So all this is done automatically at night while the patient sleeps. And if nothing changed, that patient would stay at 4. For this example, the patient rolls. The device then suspends therapy for about 30 seconds to a minute, and then everything would start over again. And this is an example that you'd see if you brought the patient into the sleep lab, you'd see this going on real time in the lab. Now, it is a neurostimulator, it takes a follow-up. So one of the things as you think about patients for this type of a therapy is they need to be able to get back into the clinic for those follow-ups. So it is a little more of an intensive follow-up than, for example, auto CPAP, right? They need to come in for a follow-up to have the therapy activated at about 6 weeks. Then there's a few visits, usually between 2 and 4 visits to personalize that for the individual patient. At the end of that time period, there is a sleep study that's done. Oftentimes, the first couple might be done in the sleep lab. And we find that as our sleep physicians get accustomed to the therapy, sometimes patients that are well treated may just need a home study. But we're also finding much more complex patients with central sleep apnea than we ever expected. I've now decided that anyone with central sleep apnea is just complex by their very nature. They are much sicker patients and they have many more comorbidities than a healthy obstructive patient. And so some of these patients may still need to come into the sleep lab at the end of that titration period for things like restless leg syndrome or insomnia, those types of things. But long-term follow-up is very simple. They come in every 6 months, have about a 15-minute to 20-minute visit, battery gets checked. And most of those diagnostics can be done based on the diagnostic reports within the device. So this is a picture of the programmer itself. This is the opening screen. There's a lot of information here. And obviously today we are not going to go through what everything is, but there's a nice battery sensor here on the left. It'll tell you if the battery is functioning well. And this tells you how the device is programmed, gives you all the information you need to know how this is programmed. But you can see along the top are all the different types of information that you can get from the device itself, some of which give you information about how the patient's doing and some about how to program. But some of these things are just even how much activity is the patient doing? Are they more active than they were before? Are they sleeping at night? Are they getting their 8 hours of therapy that you want them to get at night? And to document that. And that's what they'll spit out reports like these that you might see from any other report. In the middle here is your diagnostic report on therapy duration. So if you need to report that for some reason, you have a diagnostic report that gives you that length of activity. And you also have some efficacy data here on the far right that's going to tell you how well that's functioning. But though probably the one that gets used the most is this top left one. That's what angle is the patient sleeping at. It helps you understand, is the patient going to bed when your therapy is programmed for? When is the patient lying down? When are they up? And you can therefore change when your patient's getting therapy based on, are they going to bed when you have this therapy programmed for and when they tell you they're actually going to bed. And the device actually has the ability to show you breathing. So right now you can see at least 1 minute every 15 minutes throughout the night. You can go through this is the respiratory signal from the device. It'll tell you if that patient is breathing at the rate that you want them to breathe. And you can just quickly go through and see what it looks like on respirations. And then the latest version of the device that will hopefully be available soon in Europe can actually give you a full night of respirations. So you can actually see very similar to like a home study. It gives you essentially an RDI, but no oxygen, unfortunately. Will show you exactly each breath and show you the stimulation at that time. And you can basically go in and look and see exactly what that breath looks like with each stimulation level. So really trying to give you a good sense of what's going on with that patient with this therapy real time for at least one night every time they come in for their visits, putting this in your hands. So let's talk a few minutes about the clinical data behind it. It is a newer therapy. This study was completed in 2016, but not everybody has necessarily seen the clinical data, and we do have studies going on right now. The Remedy System pivotal trial was a randomized study with blinded core lab, randomized treatment versus control. It was not a heart failure study. It was a study that was looking at all patients with central sleep apnea. However, about 2/3 of patients had heart failure. The other third was a combination of patients with idiopathic central sleep apnea and patients with, say, stroke and hypertensive heart disease. They were primarily male. You can see here, age 65. BMI was right about 31, ejection fraction 40%. And they did have very high AHI. So AHI was 45. And the study met, this is a very busy slide, but we'll dive in quickly to some clinical data. The study met its primary and all 7 of its hierarchically tested secondary endpoints with a 41% between group difference of its primary endpoint of a 50% reduction in AHI. And we'll look at what that means to the patient. So this therapy is very effective at treating central events. So you can see here, this is 2-year median data, that the central apneas were treated very, very well with this therapy. The dark blue here is the obstructive apneas. And this therapy is not going to open a closed airway. So if you have a lot of obstructive apneas, those are going to be left over at the end, and they may need, if that number is very high, may need an alternative therapy. The hypopneas, so central hypopneas are stabilized very quickly with this therapy. But at the time that this therapy was being, that the study was started, was before we had criteria to distinguish. So they were not classified as obstructive or central. We do have a project right now that somebody's going to go back and look at those for us and determine that. But what was left over primarily appears to be, based on some spot checks so far, some obstructive hypopneas. And then some of it has to do with the way that this therapy walks up, as we showed earlier. And the effect is very sustainable. You can see here, we have data out through 5 years in these patients, that the apnea reduction and the central apnea reduction seems to be very sustained. what you end up with is primarily obstructive events that may, if it's high enough, may need a little bit of treatment for, you can use all obstructive therapies with this. So we do see occasionally people use a dental appliance, positional treatments, or a little low dose CPAP with this therapy. Arousal index improved, and here's where, as you look at this therapy, you really see the impact of treating these centrals on patient outcomes. Arousal index improved by about 45%, and that was maintained out to 5 years. Patients have a very strong improvement in clinical symptoms, both there. Here you see sleep quality. So percent of time in REM sleep improved. That was maintained out through 5 years as well, again, with a patient population starting at age 65. In patients, that is one of the things we hear from patients, is that they dream again. There has been, there was another meta-analysis done recently showing continued effects on AHI among all the different trials that have used this, that have looked at this therapy across all the different studies. There is pro trials, and in Bauenhausen with Olaf Oldenburg actually did their own independent study, and they also saw improvements in AHI, as you can see here, but also starting to see now, this was a prospective study, the single arm, some improvements in things like 6-minute hall walk test, improvements in time below 90% as well. But this particular study didn't show improvements in ejection fraction. And then finally, this is the improvement in patient symptoms, patient-reported symptoms. You can see the improvement in daytime sleepiness. These patients, because it came up earlier, didn't start with a high Epworth. They started out with an Epworth of about 10, but this has been very consistent and sustainable out through 5 years as well, of an Epworth improvement above 3.2. And these patients tend to have a lot of fatigue, is what they complain of, and less sleepiness. And FSS improved by more than 0.5, which was maintained at least out to 2 years, which is when we measured it. And then patient global assessment, which has been more used in cardiology, but 79% of patients said their overall health improved. 60% is above what's considered kind of the placebo effect. And importantly, the control group looked very much the same when they were activated. And then 95% of patients said they would be willing to have the procedure done again. Now, it's an invasive procedure, so there is, there's inherent risk with anything that's invasive, right? So we talk about where it might lie in the treatment continuum, typically after something less invasive, right? But 91% freedom from serious adverse events, all of those resolved without any long-term clinical. So those are things like like an infection that resolves with antibiotics, nothing that causes any long-term harm. Probably the highest risk is of lead dislodgements. Patients going home, especially after COVID, patients are going home from the hospital very, very quickly now. And what we're seeing is that that patients go home and start getting very active again because they're feeling well. So we're having to remind them to go home and take it easy again until that lead heals in. We get asked a lot about heart failure. This was not a heart failure trial, so limited data here, primarily for safety in light of some of the other trials. You can see here no difference in mortality. In the middle is time to first heart failure hospitalization, going in the right direction, but we need a lot more data. And then on the far left is a trend in the right direction, but very small. And we definitely need more data on ejection fraction. So from a patient perspective, we can't say anything yet on heart failure in these patients, but luckily we don't see any evidence of any harm with this population. So we just continue to need to grow more data. We're doing that right now. We have a large ongoing post-market study. We are always interested in doing more studies, and look forward to the discussion and answering questions. Thank you.
Thank you very much, Dr. Germany. I propose that we take questions for you after a very short introduction, and we may then proceed to the plenary discussion. I just would like to remind the audience that Sleep Europe, the biannual ESRS Congress, will take place this year from September 24 to 27 in Seville in Spain. I can say that we already have a preliminary program with exciting symposia and top-ranked keynote speakers. The final program and facilities for abstract submission will be announced soon. So I would recommend you don't miss the event. And now we can go to the discussion. And so there were questions for you, Robin, on heart-end outcomes, but you showed the slide. There's nothing available yet. Or could you speculate on cardiovascular outcomes? Would it make any difference, you think?
Well, certainly, you know, I hope that that we get those data at some point. I think one of the things that we're seeing is that the patient population is more complex.
Mm-hmm.
So our population that was even in the pivotal trial was a little different than SERVE. I think the patient populations between SERVE and Advent, as we deep dive into them, look quite different.
Mm-hmm.
And I think one of the important things is, as we think about the next cardiovascular outcomes trial, is to maybe take a moment and deep dive and say which patient population. I think the data from France has been really enlightening to say which population do we want to pull together, regardless of which therapy we're looking at, which is the group most likely to benefit, and then to put that group together for this next trial.
Yeah, people who are susceptible for the positive effects of the treatment. You had different categories, not only heart failure but also others. Was there a difference in effectiveness among these different categories?
There was not. So we had a group of about 14 idiopathic patients. They've been published separately. They did very well with therapy. We did not have chronic pain patients in that study. So we do have a study ongoing right now with those patients that hopefully will be published before too long, because that's a really interesting group of patients. But we didn't see any evidence with or without heart failure otherwise.
Yeah. So the method is, and that's one of the questions here, the method is unilateral phrenic stimulation. And that is on purpose, I presume. Or is there a rationale for doing bilateral stimulation?
So there are actually a couple of other bilateral stimulators that are actually out there, and they're vents. So on a basic, kind of a more basic level, they do actually take over breathing. And you can program them in. They're surgical. The technique is a little bit more invasive, but they're truly ventilators. And they're great for what they do. Spinal cord injuries, those types of things. But the concept here is a little backwards to them. So they tend to overdrive breathe. They deliver very large tidal volumes. The concept here is opposite of that. It's a little bit, instead of a bigger tidal volume, very similar tidal volume with more of a longer breath and a slower respiratory rate. So kind of calming the system versus overdriving. And we found that then if a patient does end up getting ill, so gets a pneumonia, gets massively fluid overloaded, having that other diaphragm free allows them to breathe at a faster rate if they were to get into trouble. And that's an important thing for this population.
Maybe a last question for you personally before we have a broader discussion. We have a couple of minutes left. Is it sometimes indicated to combine this phrenic nerve stimulation therapy with other therapies, for instance, with CPAP, if you have residual amount of obstructive sleep apnea that you cannot control with the stimulator?
Yeah, we're seeing now, especially that it's on the market, I would say about 10 to 15% of our patients are in a combination now of CPAP and the phrenic nerve stimulator, and usually at much lower doses. So these are patients that that didn't tolerate PAP therapy at all. And we do have it's more of a case study, I would say, than a publication, where oftentimes the pressure though that's needed is much lower than what they needed prior to phrenic nerve stimulation.
Yeah, thank you. I have a question for the panel, also coming from one of the delegates here, is how can you explain position-dependent central sleep apnea, and how do you treat it?
If you allow me, I can answer this question because I published some research on that. Of course, you have different categories of central sleep apnea, so not all will present with supine related central sleep apnea, but all can have it. It's not a hypothesis, but what we speculate at least is that patients with a more pronounced change in the functional residual capacity, so the FRC, have a higher likelihood to develop central sleep apnea in the supine position. So if the FRC is lower in the supine position, they will have a higher likelihood, and that's because the FRC is the oxygen reserve. So the lower your oxygen reserve, the more instability you can induce in the feedback control system. And maybe also changes in the blood flow to the heart that are different in the supine versus in the lateral position. So that can also contribute to this presentation of central sleep apnea.
Yeah. Maybe a question for Jerryll. There's positional therapy, and it's been one of these vibrating devices that alert people that they're sleeping on the back, has been developed in the Netherlands. Do you have any experience with such position trainers in central sleep apnea? Does it work?
I have very little experience with this treatment. I know in the Netherlands there also have been done some studies. I think Sebastian Overeem together with the OLVG group, and they had some positive results. But actually, I have little experience with it.
Yeah, I can add because we also participated in this trial, and it was in 15 patients, and there was a huge improvement in the position, the time spent in the supine position, resulting in a substantial reduction in the number of central events. So that it really works. It's of course, very easy to understand. If you avoid supine position, then this patient will not have central sleep apnea at all.
Yeah, but the difficulty is often if a patient has problems lying on his sideway because of his hip or his shoulder or back problems, or he doesn't react enough on the stimulation. So you need the perfect patient for this.
Yeah, that's true. We had 2 dropouts. One, indeed, because he had orthopedic problems with his shoulder, and another one who used CPAP before, and then decided to interrupt the participation in the trial because he felt much better with the CPAP and with the positional trainer.
Yeah. Thank you.
But it is. I mean, you can try. If it doesn't work, you can find another solution. Yeah.
Well, there's still a lot of unanswered questions in the Q&A box, but unfortunately, the time of this broadcast is running out, so we come to a close. And I would like to thank the speakers for their excellent contributions from this really for having a peek into the preliminary results of the studies with phrenic nerve stimulator. I also would like to thank the organization and the audience for being with us, for asking these questions. And finally, Zoll, who is the prime sponsor of this event. And with this address, I would like to close the session. Thank you all very much.
Thank you, Dirk.